want to welcome you all to our Nursing Grand Rounds presentation this month. I'm Jennifer Minhas. I am the Nurse Manager for Outreach Education, and we're just thrilled to have you all here live at Seattle Children's and joining us from around the region. Yes. Our talk is Gastrostomy Tubes, Everything You Need to Know for Outstanding Nursing Care. Our speaker is Jenny Kreis. She's our nurse practitioner in pediatric surgery and reconstructive pelvic medicine here at Seattle Children's. Jenny has a wealth of knowledge and experience in feeding tubes for children and has provided her expertise for many articles and development of a clinical pathway on feeding tube placement and care. So we're thrilled to welcome you, Jenny.
Thank you so much for that kind introduction, Jennifer, and thanks to everyone for coming. It's a very fun topic today, and I'm so excited to share this with nurses because it's one of those little areas where what we do as nurses has such a huge impact on quality of care for families. And G-tubes themselves have just really revolutionized quality of life for kids over the last few decades. We've gotten so much better at them. We put them in very often these days, and we see so many of them across all domains of kids that we take care of here at this hospital. So having a foundational knowledge of G-tubes and what you can do to take care of them and what you can teach families to be successful at home is just one of the most I think, exciting nursing skills that we can have. So it's really my pleasure to be here and to go over this with you. I want to encourage you to ask any questions that you have. If I miss anything, we'll have time, and at the end, I'll do a little demonstration for you of changing a tube and just a couple of the tips and tricks that I share with parents every day in the clinic when I see them post-operatively. So I don't have any disclosures. However, a lot of things that we do around G-tubes are off-label, and there is not very good research around the treatments that we use, for example, for a granulation tissue. So you'll hear me talk about some of those things, and they are used off-label and very commonly used around the world for this. So it's not like we're doing anything totally crazy. Here's my objectives. And I hope you'll hold me to all of them. I want to go through your standard post-operative care and talk about both things that come up in the immediate post-op period, because that's when a lot of the inpatient nurses will interact with families, but then also the long-term issues that come up so that we have a basis for knowing how to handle some of those. Some of the tools available for optimal G-tube care, including the tools that we have here in regards to policies, procedures, pathways, things like that. Who to call and when to call if you're having a problem that you can't handle yourself. And then mostly how to help families be successful with these tubes at home. So just to start from the beginning, to give a little bit of background on how we got to where we are today. Around about 2011, some families came to hospital administration and said, geez, you know, this experience of having a G-tube has been really chaotic for us. It hasn't been very smooth. We don't know who to talk to, who's in charge. And so we did a standardization project around that year and started to develop some more clear pathways in regards to how you get a G-tube, what the process is like moving through life with a G-tube, who's going to manage it long term, who makes the decisions about when to place it, how long to use it, and when to get it out if that's within your developmental capability. So we've worked a lot on getting this standardized, and I think it's a lot more clear for everyone now, and I hope that that becomes illuminated through this presentation. Some of the elements of success for families in regards to G-tubes, I want every family to feel like they can manage this 100% at home easily, with their eyes closed, hopefully. You know, it's so easy to take care of these tubes long term, and I want them to feel comfortable and relaxed, and like this is just like a pierced ear or some other little device that, you know, they know how to take care of, and it's not scary for them. And the way to get to that empowered state is to give good education up front, and that starts with all of us in our unique roles, interacting with the families around these G-tubes, giving them specific guidelines about how to take care of it and what to do if they have a problem. And then another key aspect for families is our availability to them. So if they do have a problem, who do they call? How do they reach that person? How quickly is that person going to get back to them? And how consistent are our messages going to be throughout the organization in regards to what we tell people to do at home? We want to give a really clear message that's the same whether you're talking to the charge nurse or the surgery nurse or the GI nurse or some other nurse in some other department. So getting back to that whole pathway with the standardized approach to feeding tubes, we have a process now whereby everybody that has a need for a feeding tube needs to start with a feeding tube home. So somebody, some program needs to be able to manage the referral process and get the pieces into place before this kid is just going to go to the OR, for example, and get a tube put in. Because we don't want to do that without having the right things set up from the get-go. So that's the concept of the feeding tube medical home. And almost all of our kids here that need a feeding tube have a medical home. Like they started in some kind of program because there's a reason that they need the G-tube. So for example, I'll give you some of the common medical homes. Somebody born with craniofacial abnormalities that can't eat properly, who starts out in craniofacial and proves that they can't meet their nutritional needs by mouth, they would get started on the G-tube referral process by craniofacial, which would be their feeding tube medical home. And then you can generalize that to all the other programs, because a child that has significant neurocognitive delays and who's followed by a neurodevelopmental team would probably get their referral started in neurodevelopmental, and that would be their feeding tube medical home. So, you know, as the floor nurse, you're not so worried about that, but just to know that there is actually a process and a system and an ownership sort of model for who's going to be managing this whole situation going forward. The family is not out there in the breeze on their own. They have a support team behind them that's going to help with that. And some of the members of that support team within the medical home program, all the medical home programs have a dietitian, so they all have nutrition follow-up. They all have a process for receiving oromotor therapy so that they can continue to improve their oral skills, so that at some point, hopefully if it's within your developmental potential, you will become orally independent and be able to get rid of your G-tube, hopefully. So we give everyone that opportunity for ongoing therapy. And then before you get your G-tube, you have to have home care equipment set up. And part of the pathway, which we'll review in a minute, is you need to have had a little bit of a trial with that equipment and the setup of it so that it's not all new to you on the day you get your G-tube. Yeah. So really good question. Is it ever the primary care provider who's the medical home? Unfortunately, it is occasionally the case, very rarely. If you don't have any other medical home, and let's say you live in remote Alaska or something, and you need somebody to manage who isn't part of a program here, the primary care provider can be the medical home, but there are some downsides to that because most primary care providers don't have a dietitian. They may not have the time to manage the oral therapy or set up the home. You know, there's a lot of other pieces and parts to it. So although it is sometimes the case, if that is the case, we have to kind of give that some special handling so that they get the supports they need. All right, so back to the whole process of getting a G-tube. This is a little bit of the backstory, and I promise I'll get to the better hands-on stuff pretty quick. Okay, so part of the backstory is that you have to have a readiness checklist completed before you get ever scheduled for a G-tube surgery. And that's not really a job that we would expect nurses outside of surgery to participate in, but our clinic nurses participate in this intimately. They get the G-tube readiness checklist started with the family before they ever come to clinic so that they're all packaged up nicely by the time we see them. And if you're interested in the details of where that lives, It's on ad hoc charting. It's called the Gastrostomy Tube Readiness Checklist. You have to complete all of these things on the checklist before you can get scheduled, and I'll give you an example of that in a minute. So this is kind of a diagram of the readiness pre-work that exists that starts in the clinic, where the referring provider or the referring medical home team decides to make the referral because this child is not thriving on oral intake alone. So they'll recommend a G-tube, they'll call to get scheduled, but before they get scheduled, they have to fill out this checklist and get all of these support things in place, and I'll give you a little bit more on that in a minute. And then eventually, when all that's in place, they can come on in, see the surgeon, get scheduled, get their surgery, etc. Lots of detail around the gastrostomy readiness checklist, and this is the job aid that goes with it. So if you happen to be one of the nurses that's ever been in the situation of having to manage this, these are some of the support tools that exist for you. Job aid continued. Okay, so now let's actually, before I get into this placement technique, I just want to make one more comment about this whole readiness pathway and the preparation and the back work that goes into referring someone for a G-tube, because we've made a little bit of a transition, if I can back up a second, to this job aid. So in the past, the outpatient nurses were the ones that were getting all of this stuff set up for the families. But what we did realize is that a lot of families are not only capable, but actually desiring to do some of this themselves. And that the more ownership they have, the greater empowerment they feel around this whole G-tube process, and it helps them to participate in figuring out who's their medical home for feeding tube stuff, who is their home care company going to be, who is their therapist going to be, who's their dietitian. These are really key questions that we want them to be able to know for themselves. And so one of the things that we've started now is this new pilot process of having families fill out their own readiness checklist using a website called Inside Out Care. Some of you might have heard of Inside Out Care before. It was started by a children's parent, and it's utilized now across several different domains, but one of the main things that is helpful for is helping parents organize their feeding tube care, and they can go on and do their own readiness checklist now, and the nurses can coach them with that and make sure it's all complete before they actually come to clinic for their pre-op appointment. All right, so now we're getting to meet the surgeon or the gastroenterologist or the interventional radiologist, because there are actually 3 different ways that a G-tube can be placed here at this hospital. And although the majority are surgical, some are placed in endoscopy, and some of a kind of a very small fraction of the total G-tubes are placed in IR. So these are the 3 methods, and it really helps to know this, because if you're downstream trying to deal with a G-tube problem, it's really helpful to be able to click back in the chart and see how is this placed, who placed this actually, because that will help you determine who you're supposed to be calling for troubleshooting issues. So the majority are placed surgically. Most of them are laparoscopic, some are open. Most kids stay 1 night in the hospital. Some of the, I think I have some more slides about this so we can go into a little bit more detail. And if you want more detail about it, I'm happy to provide it. Surgical tubes, just in a nutshell, are sewn. So the stomach is brought up to the abdominal wall inside, and 4 vertical mattress sutures are placed internally. There's nothing that you see on the outside, but it makes for a very stable and secure connection so that the stomach stays right up to the abdominal wall, and there's less chance of any leakage or misplacement of the tube. So it's considered the most stable type of tract. But it does have a slightly longer recovery time than endoscopy. So endoscopy is also a very good way of placing a G-tube. And that note, if you've ever had the experience of trying to figure this out in CIS, it's confusing because there's a dual note in there under the report. There's both an endoscopic report with the gastroenterologist's name, and there's a surgeon report, because that's a kind of a two-provider procedure where the gastroenterologist passes the endoscope and the surgeon stands on the outside and makes the tiny incision. So that method, they string a tube down through the throat into the stomach and then pull it out from the inside out. It's a long tube with a bolster, and I'll show you some pictures in a minute. Percutaneous IR, they end up with a skin level tube just like the surgical tubes, but there's no sewing involved, so it's a little bit of a less stable tract. So you've probably seen some of the long tubes before. They're not used too often, but sometimes you'll see them. The endoscopic tubes, the PEGs for short, are all long tubes initially, and some of them are later transitioned over to skin level tubes. Then we have our long Malacot tubes, which are kind of reserved for neonates, usually very small neonates who are kind of unstable, who don't do well with a longer anesthetic, so that they can quickly put in a long, small Malacot, and we can transition that over to a skin level device later. Here are some of the long tubes. So let's use my pointer. So this one right here on the left, this is a PEG. See this soft silicone mushroom thing? So that's what's holding the PEG on the inside. Here's the bolster that you see on the outside of the skin. That was placed down through the mouth initially. The center one here, this is a long length, this happens to be a Mickey brand long tube. It's held in with a water balloon. Here's the bolster on the outside of the skin. Why would someone ever have that, you wonder? Well, look at how long a tract this kid has, super long. So there are some special situations where kids end up in these long tubes, either temporarily or permanently. This here is a Foley catheter. Haha, you all know this. This is very familiar to you. Why do we have this on here anyway? Well, because sometimes in a pinch, if your tube is out and you have nothing to put in and you need to keep that hole open to preserve the opening, we do put a Foley in temporarily, but not as a permanent situation, because look at that long end, which can rub up and cause like an ulceration on the inside of the stomach if it's left in as a permanent tube. So those are never permanent, but they can help you out in an emergency situation. Here's a Malacot. Over on the right, a small, super flexible, thin, it's held in with kind of this little basket weave thing. These are so easy to pull out because there's not much keeping that in the skin at all. So these are usually very temporary, and as soon as possible, we put something a little bit more secure in. Yeah. So on these, let's look at the PEG up here. So see this main port here? That's where your purple end of your enteral feeding set would plug in. And then the side port is for meds. There's no balloon port on this PEG. That's held in with a rigid, like little plastic thing. Now on this Mickey tube, this, you can't see it from this angle, but this is marked with a BAL for balloon, and it has the amount of water that you put in the balloon. So that's the balloon port there. Only water for the balloon goes in there. This side port is the med port, and this large central portion is where the feeding set plugs in. It's really a good question. Thanks for asking that, because we've had a few nursing errors where somebody tries to put meds or something in through the balloon port on accident. It is possible to do that. Does it really hurt anything? Well, maybe not, but if you put very much volume in here, you'll probably break the balloon. It's definitely not ideal. So take note of where things go. Okay, then we'll talk about the skin level tubes, and I have a little demo set up here at the front that I'll go over in a minute, but I also have a picture of it too. There's the firm mushroom retention types, which is the old style barred. They've been around since early 80s. Once in a while you'll see one. We still have some out there. And then we have the wildly popular balloon style tubes, which are at least 90% of the tubes that you'll see now, if not more. And they have a lot of advantages over this firm style barred. The advantage of the barred is that it's the lowest profile, so sits very, very flat to the skin. Disadvantage is that parents can't change them themselves, and they hurt to change. You have to yank them out, and it's kind of, some people use the word barbaric, and not really. It's very quick. We don't use anesthesia. You can do it in the clinic, but because of that whole clinic change thing, it's quite a disadvantage. So you have to really be willing to accept that if that's the tube you select. Maybe some reasons why somebody would select that are because they absolutely cannot and will not learn to replace a skin level tube at home. They just know that about themselves, can't do it, won't do it. I'm blind, I can't see, I have poor dexterity, whatever. So there are some situations where it's the right choice. And here is what they look like. So this one, oops, get the right button here. This one right here is the barred. See how nice and flat that is? These last a long time, like several years in many cases. If you let them in more than a couple years, eventually the silicone degrades and they break. And other ways that they can break are the flap can rip right here, or the stem can crack, or the little plug can fall off. So they do fail, and when they fail, they have to be pulled straight out through the skin and pushed in with a tool. So a little bit uncomfortable to change these bards. That's the downside. This one in the center is a Mickey. We used to stock Mickeys. We stocked them for 25 years or so. And that's a good balloon tube. There's still a lot of them out there. In 2017, we switched brands to this AMT Mini, and if you notice, they're very, very, very similar. Not much difference between these two. They both have a twist lock extension set mechanism up here. They both have a balloon port right here, and they're both held in with a water balloon. Well, why did we switch anyway? Well, this one is about 33% lower. A little hard to appreciate, but it is a little lower. Super soft. And the balloon, which is a little different shape, it's a flatter style balloon, so it has a much greater resistance to being yanked out, which is a big advantage for families. And then one of the kind of cutesy things about it is that it has a glow-in-the-dark ring that matches with the glow-in-the-dark connector, and you'd be surprised what a big selling point that is for families. So families really have enjoyed this. It's been a very successful transition for us. But as nurses, what you need to know is that extension sets are compatible between these two styles. So if they come in with one kind of tube and you don't have that tube here, you can still use your hospital stocked extension sets in either tube, vice versa. And families, it's really their choice. Some love the Mickey, some love the AMT. Home care stocks them all. They can have whatever type they want for home. Very, very popular. Very easy to change at home. Very safe, very gentle. Here are some of the extension sets, which most of you are familiar with these, but I want to go through it. If you aren't familiar, it's very important to appreciate. The barred, this is that barred tube that is less commonly seen, but you need to understand the differences. So the valve, the little one-way flap valve that keeps the stomach contents from reflexing back up through the stem, it's right here. It's down in the bottom of the stem where it meets the mushroom. So in order to vent a barred, if you want to get gas out, if you want to get stomach contents out, if you're trying to drain the stomach or relieve gas pressure, you have to order a decompression set with an extra long end that matches the size of the tube. So if this is, for an example, an 18 French 1.7, you would call up and order an 18 French 1.7 decompression set from CS, and they would send you this extra long thing that you can then push down through the center, open up the valve, and vent the child. Sometimes it's a commonly made mistake that people think that the valve is in the top, like it is on the balloon tubes, and they try to vent a kid with this, but they're nowhere close to the valve there, and it doesn't do any good. So you have to vent with this. Here's the 90-degree feeding set, and it goes in not with a lock mechanism, but just with a friction push. It kind of grabs on and stays in by pressure. The barred extension sets that we have here in the hospital do not have feeding ports on them. They don't have side ports, but they do make that kind for home use, so you can order the nicer ones for home. It's such a low-use item around here that it's not really worth it to us to stock every possible accessory because they're just not utilized that much. Okay, here's the skin level balloon tube. This is the AMT. This is what we use here. These are all the tubes we place now, the skin level tubes. This is what the water balloon looks like inflated inside. The food goes in through the extension set, down through the stem and through this center hole. The extension goes on with a push and twist, so you have to line up the black mark to the black mark, push and twist, and then it's locked. These extensions, interestingly, have a 2-week shelf life. And home care sends out 1 per week so that you have 1 for home and 1 for school, or 1 for dad's house and 1 for mom's house or something like that. You rinse them out with hot soapy dishwater, treat them like dishes, and then reuse them for a week. And at the end of the week, you start with a fresh one, only because they get really filmy on the inside. You can't clean them that effectively, and after a week, they need to be replaced. Now, the tubes themselves, the whole replacement kit, insurance pays for 4 of these a year, so you can replace it as much as every 3 months, but our standard is every 3 to 6. The balloons really have at least a 6-month life, so there's no need to change it every 3 if it's working fine and the balloon's intact. So 3 to 6 is the standard that we teach parents for changing. There is the green glow extension set I was telling you about. This glows, and then this glows. And notice this slip tip syringe here. So you need a slip tip to manipulate this balloon right here. A lure lock does not fit well on this, and it's designed not to accept a lure lock. So if you're checking the balloon, adding water to the balloon, or changing the tube, you'll have to get a slip tip. That's what comes in the kit. But if you don't have a kit with you, you'll have to grab one. I'm kind of giving a lot of information here, and a little bit applies to some of you and some of it doesn't. I know that we don't have our staff nurses changing G-tubes on the floor here, but you know, many hospitals do, and it's not really outside your nursing scope. However, we've made it that way here because of the education and credentialing, like the, what's the word when you have to keep up your skills every single year? Like it's competency, yeah, the ongoing competency to like keep people skilled in doing this. It's a lot of nurses to keep competent every year when it's a rare skill. So we just have chosen not to make it a nursing skill here. But parents do it all the time at home, and because they're used to doing it routinely on their own kid, they're really good at it. Okay. Here's an up-close look at the lock and twist. So here's the black mark that you're going to line up to this black mark. Push, twist, and then it's locked. Okay, so now let's get to the nitty-gritty about what you're going to see problems around these tubes, and especially right in the post-op time frame. So imagine that this is a piercing and you're getting a piercing into your stomach, only it's a really big hole, a lot bigger than an earring, and it's going to act the same way. So it is going to crust and drain little bits of gooey stuff of every color. Everybody's crusts and drains, and they all crust and drain for months. So if you remember getting your ear pierced, some of you do, when you were little, you had to wash your ear like twice a day for 8 weeks or something. Same thing here. It's going to crust and drain, and you just have to clean it while it heals. So all that crusty, drainy, normal. And you're looking at this redness and you're going, ooh, is that normal? Yes, it's totally normal. Because when you're wet and you're having these gooey goos on your skin, it does get a little red. It's like a little bit of a moisture rash. So that is not anything that I'm worried about at all when I look at this. That just needs to be cleaned a little bit, that's all. It's really, 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 really important to tell parents that they're going to crust and drain. That's probably the most important thing you can tell someone before you send them home from the hospital, because they see this yellow stuff and they say, oh my gosh, it's infected. That's pus. That's what they think. It does look kind of pussy. It looks like, nose snot, and it might be green or yellow or golden or even bloody or something, and they really panic when they see that. They think it's a big problem. But if you tell them to expect that and they know it's normal, then it really puts their mind at ease. Here's a bard with a little bit of red and a little bit of crust, and that just looks great to me. I don't see any problems there at all. Let's back it up just a second. So you see how much stem shows there? People are like, oh, that's too loose. That needs to be downsized. Nah. Loose tubes are really good. You want to have a little room so you can clean under there every day. And also, like, people's tummies, they kind of like go up and down depending how full you are. So having a loose fit is very desirable. Loose is always better than tight. Loose is great. So you don't need it to fit like super snug against the body wall. In fact, loose is better. Air circulation, less granulation. Loose is great. Okay, so here's somebody who just had their surgery 2 weeks ago, and they're presenting in the clinic for their post-op clinic appointment, and this is how they look. So this kid had an open incision, and here's their healing incision. It looks really beautiful. And here's their tube, and that looks really beautiful. Really, really beautiful. Like that's an A+++ situation there. Okay, now, probably most of you have seen this type of stuff. So even from like 10 feet away, you can see this kind of like bulged up, wet red stuff there. That's our most common nuisance issue around G-tubes. Everybody has seen this from time to time. It's granulation tissue. It grows in, get this, 2/3 of all G-tubes are going to grow this stuff. So it is more common than not. You're going to see it. It happens. It's just a nuisance. It's not a danger to the child. It's not infected. We don't need antibiotics, nothing like that. And sometimes it doesn't even cause that much of a problem. Like maybe the kid doesn't really feel it. It's not bothering them. The tube's not leaking. Everything's fine. If it's a problem, there's a couple ways that we get rid of it. Steroid cream is our first line of treatment, and the reason that it's the first line is because it's non-painful, it doesn't sting, it doesn't stain, it's very easily and readily available, it's cheap, so it works really well to kind of shrink down all this granulation tissue. A little bit of steroid cream, not on the skin, just on that raised bunch of stuff, morning and night for a maximum of 2 weeks usually takes care of it. However, it does come back a lot, so sometimes once you stop your steroid cream, it bounces right back and it looks just like that. The next day after you stop your steroid cream, well, is it bothering them? Sometimes I just wait out this granulation tissue because it's really a problem of the early months, and it does calm down eventually. But right away, like the body just sees this foreign thing sticking through there, and the body is designed to kind of close all holes. If you get a cut or a scrape, it closes up really fast. And same thing here, the body is like working to close this weird hole, and that's what this overgrowth of extra granulation tissue represents. Once everything is well healed, months down the line, the body stops fighting it, and that granulation tissue is much less of a problem. Now, if you have granulation tissue that's causing a lot of leakage, causing a lot of pain, not responding to steroid cream or incompletely responding, then our second line is silver nitrate sticks. Those work also very, very well. Very established standard of care for getting rid of granulation tissue. The thing about silver is that, as a lot of you know, it stings, sometimes really badly. It stains everything it touches. It burns everything it touches. So if this kid is like thrashing around while you're trying to put the silver up here and you get the silver touched on their good skin, they're going to get little burn marks from your stick. So it's harder to use, and therefore, if you have something that's easier to use, this is first line, this is second line. Okay, so here are some bigger problems. So we talked about the little problems that are so easily dealt with. Granulation tissue, normal drainage, tiny bit of redness. Those are all the easy, normal, expected things. Here are some of the more significant things that you will see and you will encounter. And the biggest, baddest problem you can have with a G-tube is for your tube to get pulled out right away. So if your tube falls out in the first 3 months, it is kind of a big deal because you haven't been trained to replace it. It's not really safe for parents to be shoving things through a new surgical site, so they have to come in to get it replaced. And this demonstrates, that type of situation. New tube, new hole, tube out. Have to call, have to bring them in as soon as you can. People always ask, how long do I have? I live in Lopez Island. Do I have 4 hours? You can only do the best you can do, right? We used to send people home with Foley catheters, and we really try to avoid doing that now, because if you're shoving stuff through a new site, you can cause more damage than you're doing good. So just cover it over and get them in as soon as you can.
When you say come in, they come in through the ear.
Yes, they usually do. These things very rarely happen like in the business day. And sometimes we can fit them into clinic, but it's pretty hard, to be available for those kind of drop-in things. So usually it is the ER. And the ED is super good with G-tubes too. They have tons of experience. Now over here we have a pretty like a little bit of a more significant skin breakdown. This kid has wet, macerated, red skin farther out. This is actually really common on our hospitalized kids. And I'm sure that if you work in the hospital, you've seen stuff that looks like this before. And one of the reasons that G-tubes act up so routinely when you're hospitalized is because sick kids are really sick. Like they're sick with something, that's why they're here, and they're usually catabolic, they might be dehydrated, they might be fighting an infection somewhere in their body. When all that's going on, the body cannot keep this hole sealed up nicely. It just can't. It's kind of like fails everywhere. So your G-tube will commonly act up during acute illness episodes, and that's why in the hospital G-tubes act more problematic than they do at home. Because when you're healthy, the body keeps it healed up beautifully, but when you're sick, sometimes it's harder. Here's a situation where, look at how stretched out the stoma has gotten, and this thing is leaking like mad, and they have a decompression set in to try to relieve the pressure in the stomach, and I'm sure they're doing some kind of dressings to this sore-looking skin. This is kind of hard to tell in this light, but if you can appreciate how far out the erythema goes onto the body wall, this is a true G-tube infection. So what I tell all parents in the clinic is that put your fingers down on the red area. If your redness expands more than 2 fingers out onto the body wall in any direction, that's not normal. Little bits of redness, fine, we can deal with that. But big, big red that's more than 2 fingers out onto the body wall is not expected, and that could be a real serious infection like this kid has. 2 fingers of spreading redness is really far. It's all the way down to the umbilicus. It's all the way up to the rib cage, out to the side, crossing the midline. So even if it looks red, you can use that 2-finger thing yourself. Give it a try. Is it really as red as it seems? No or yes. It helps you in your decision making about how serious a situation this could be. Okay, so here we get to kind of back to the basics of what is really the helpful things that you can equip families so that they can be successful at home. What's normal? Is yellow drainage normal? Yes. Know when to worry. Well, okay, there's 2 big things to worry about going home from the hospital. 2 big things. Tube fell out, biggest thing, very obvious, big thing to worry about. Second big thing to worry about is leakage where the formula or the food is running down your sides and soaking into your clothes or your bedding. Because a little bit of leakage is tolerable, especially if it can be contained on a little split gauze or a little button pad. But if it's so much calorie loss that it's running down your body and it's like drizzling out around the sides of the G-tube, that's not normal. It shouldn't be leaking that much. So if it's leaking that much, you actually do have a problem that you'll have to call in for. So those are the biggest things to worry about in the post-op period. Basic care is cleaning and how to hook up the extension set. So plain water, mild soap, those are the things we clean with. We don't use peroxide, we don't use any harsh things around it. Just regular soap and water is totally fine. We don't immerse the whole kid for the first week, but after a week they can be immersed. Most of the time you don't have to get into that level of detail. Just tell them how to clean it. They all have a follow-up appointment. 100% of kids come back to clinic between 1 and 2 weeks post-op, so we go over all these things in the clinic. We don't expect our floor nurses to do lengthy, extensive teaching. It's not absorbed anyway. It's not the greatest setting to do lengthy post-op teaching. If you teach, it needs to be clean, a little drainage is normal, let's practice with the extension set, do you have your home care supplies? These are the basic, if you ask like 5 or 6 basic questions, you've done your teaching. But those 5 or 6 are very, very important. Just to like have them sign out and leave without ever having hooked up the extension set, that's really doing them a disservice. And telling them that they need to call or worry for any little type of drainage is also a disservice, because they're all going to drain and they're all going to really worry when they see that, but that is normal. Okay, so plain water, mild soap for cleaning, all new tubes, crust and drain. We didn't really talk about stabilization, but I do want to talk about that because it's really important, and it's one of the things that gets the surgeons the most irritated about when they come by to see their post-op kids, because sometimes you have a G-tube that was placed, I don't want to get too close to that model because I know people at home can't see that, but if you have a G-tube that was placed last night and this morning they're hooked up to their feed, but the tubing is dangling off the bed so that the tube is sort of torqued to the side, that's not good for a new G-tube tract. It needs to be flat against the body, not, torqued to one side or another, because that'll stretch the new opening and it'll immediately start to leak and break down. So securing your extension set is really important, either with a tape and pin anchor, which I'll demonstrate at the end, or you can tape it to the body wall or use a piece of Replicare if you don't want to tape directly onto the child, but it needs to be stabilized so that you're not torquing things to the side. It's really important, especially on the first 48 hours post-op. And then when you're teaching parents to attach and detach the extension, please demonstrate it for them correctly. 2-hand technique. Use your supporting hand to stabilize that tube, so pinch it. I'll show you a demonstration of this at the end. And then attach the tube so that when you're pushing down and twisting, you're pushing against your own fingers on a secure base. You're not just one-handedly trying to jam this in on somebody's new operated belly, because that's really uncomfortable. So using a 2-hand technique and stabilizing your tube is very important. Okay, so everybody already has a home care company, 100%. Why? Because they all had their G-tube readiness checklist completed before they ever got to surgery. So they should already know who their home care company is, and they should already be receiving those supplies. And the inpatient care coordinator will fax the order for the new size G-tube to the home care company before they leave the hospital so that the family can get their spare tube sent to the house. So you really shouldn't have to do anything with that in the post-op period as the bedside nurse, because all that is being taken care of. And as I said, everyone should have a clinic appointment. Everybody should have the clinic number on their discharge paperwork so they know who to call and who to get in touch with if something comes up at home and they need to contact someone for a problem. Okay, so here's some of your nursing resources. And everything that I've talked about here is written down in various places in the hospital. There is a patient education toolkit on child that has a G-tube handout. People get that in clinic, before they ever even get scheduled. When they come in to meet the surgeon, they already get that. So I personally don't think that's important for bedside nurses to be printing that out and giving that again, because those kind of things are covered in clinic. Nursing guideline of care exists. There's a clinical standard work around G-tube. There's a G-tube policy and procedure. And your unit-based clinical nurse educator is also a resource. Inside Out Care is a resource for you as well as for the family. It's perfectly fine for you to go in and check it out yourself and see what kind of things are on there. All the families are encouraged to register. Not everyone does, but it's definitely a resource for them if they want to use that and connect with other families for tips and things like that. For issues outside my scope. So this is like, who should I call if I'm having a problem and I don't know how to deal with this and it's really affecting my patient and I need some help with this situation. So I would personally, if it's simple, and it's one of these simple things that we've already discussed, like start with your own nursing resources and your expertise. Does this need to be stabilized? Does it need a bit of a dressing around it? Is it leaking a little bit, but I could put a dressing on it and it's going to be okay? Could I watch this today and see if my dressing works? That's actually the first basic thing to do. You don't have to, very first thing, like pick up the phone and call. Just go through your thinking first. Like, is this a serious problem or is this a little problem? Is this something I know how to manage? Is this something I need help with? And if you need help, like if it's running down their sides or if it's more than 2 fingers of redness or gosh, if the tube's out, heaven forbid, then you are going to have to call somebody. And probably the first person to call would be like the assigned care provider for whatever team this kid is on, because they're going to need to know if it's a big problem. And they would probably be the one to call a consult if they need surgery, or a surgery nurse practitioner or somebody with higher level G-tube knowledge to come by and suss out the situation. So that would be the order of which you would start calling people. Those are the resources. Surgery nurse practitioners do advanced G-tube consults during the day when they're here. So those would be for some of those horrible pictures that I showed you, like really badly infected things or really badly leaking things or really terrible skin. The wound care team also looks at some of the really bad skin for us. If it's a GJ tube, GJ, J, anything with a J, special category. All J tubes are managed by IR, only because they can't be replaced at the bedside. They require imaging, to get them into the right position. If they're clogged and need to be replaced, it's going to be IR. So all GJs are managed by IR. If it is a PEG tube and it was placed by gastroenterology, then gastroenterology owns it, and they would be the ones to troubleshoot it. Okay, so this is back to what families need to succeed. I'm trying to hammer this in because I think this is the most important part of today's presentation, which is what do families really need to know to succeed. This is such a nursing realm type of education. What's normal and expected? how to clean it, what are my supplies, who are my resources, when should I worry? Those are really the key elements that we're trying to send everybody home feeling equipped to manage and answer those questions. Okay, are there any immediate? Yes.
My parents have the whole like sizing too. Like how do we know when they need to size up and who to consult?
So the question is, maybe the tube is not fitting right anymore, too tight or too loose. How do we know when it's the right size? Yeah. So great question. Easy answer. So if there's really a bunch of stems sticking up, like it's not just loose, but it's sticking out, then that's kind of too long, right? Especially if it's leaking. You know, if it's leaking, causing a problem. Some kids walk around in long tubes all the time and they're working fine. So if they're working fine, there's no real reason to go after it as a problem. But if it is a problem and it's sticking out really far, that would be a reason to resize. It's really easy, so easy to tell when a tube is too tight because it sinks into the body wall. It's like sitting in a little pocket of fat. It's like down below the skin level. It's tight. You know, you can barely lift it up to clean underneath it, and it's usually kind of hurts, and the skin is pretty red there. So if it's sinking into the body wall and it's red and it hurts, it's probably too short. So that would be a reason to lengthen the stem. The clinic that put the tube in would be the one to resize it, yeah, which is usually surgery, but might be GI. Yeah.
So when someone has a Mickey from before and they're ready to change to another tube, are they changing to the AMT tubes now, or are they staying with Mickey's?
So that's a really good question. So we only stock AMTs here now. So if you're here in the hospital and you need your tube changed, that's what you're going to get because it's all I have. But if you decide that you really liked your Mickey a lot better, that's so easy because I just order that from home care and they can put the Mickey back in at the next opportunity. The insurers don't care what brand it is, and the tubes are very similar, so a family preference. Yeah. Other question right now?
So I'm with cardiology and we are having a lot of problems with G-tube referrals right now, knowing like where to send everyone. So if we have a kid and we need a G-tube and we refer them to general surge, we fill out the readiness form in CIS, or does the GI or the surgery nurse do it?
The surgery nurse is going to help the family start the process.
Okay.
And if they're capable and willing to start it themselves, they will, or if they won't, then the surgery nurses do it.
Okay. But as far as when we put the order in the consult, we don't need to do the G-tube readiness.
Are there any surgery nurses here? Not really, right?
I would say that if they know how to do it, to start it in the clinic that it's initiated.
Our thing has been home care, like knowing who their home care company is. Like, how do we figure that out if they don't have home care for something else?
Right. And actually, this is a very good question. So I would tell you that we can't like direct people to a certain home care. You're supposed to, by law, like tell them that there are a lot of different companies out there. Here are some of the ones. They need to kind of understand which ones are preferred by their payer. So for example, if you're Kaiser, you have to use Quorum. And, you know, there's some rules around that. So you should probably, the safest thing is to tell the family, you're going to have to help me figure that out by understanding who your payer wants you to use and select one of those companies. Yeah.
And I think it's always, is this on? Yeah. It's always good if you want to just start the checklist. The general surgery nurses would really appreciate that because they can always add to it. But even if you just did a little bit of the research and like who's the owner, like basically who's going to own the patient afterwards is the real, driver of why this G-tube checklist got started in the first place by general surgery. That makes sense.
Yeah, and because it's you asking this question, like you'd already be able to say, well, cardiology is going to be their medical home, and that's like most of the battle right there. Just filling that part out is super helpful to us. Yeah.
Yeah, because basically the general surgery nurses, if they get the referral, that's the hardest question, I think, is to find out and acknowledge who is the medical home for that child. The other pieces of it, like the home care, they're happy to have, have the family look into it and get on that website, Inside Out Care, because
Yeah.
that's really helpful for the family, too.
Part of our issues with that though too is we make our kids stay local for a month, so we need someone here and then we let them go back home. So that's kind of what we've been running into is.
And usually that's really easy, though. It really is, because all the companies, even if they're, say, east of the mountains or something, Children's Home Care can start it and then transition it over to one of the Eastern Washington companies or any of the other regional companies. It's pretty common.
Do we have time for
Yeah,
a
so we're
demo?
running out of time, so I want to go through a quick demo, and you all help me out if you can't see this. I'm going to try to keep my hands out of the way, and I want the regional people to see this. Here's my baby, and she is here for a 2-week check, so I want to show you some of the things that I tell the parents. So I show them that you can pick up the tube and, put it to the side a little bit so that you can clean all around underneath and get all those crusty goopies off. It's okay to handle it like that. Everyday handling is not going to make the tube fall out. You'd have to whoosh, pull it hard to make it pull out, but you can clean all around it, pick it up, move it around. That's your normal cleaning. Here is a tape and pin anchor, and about 6 inches down the tube with the clamp above the tape wing, I put a piece of tape and then I attach that to a pin and pin it to the clothing. And then I test my anchor by pulling on the free end of the extension piece to make sure that it's not going to slip or slide. But this way, if somebody steps on the tubing or the tubing gets caught in the car seat or the stroller, the big yank is going to hit the pin instead of pulling the tube directly out. 90% of early tube dislodgements occur because the family member pulls it out, not the kid. Babies very rarely pull out their own tubes. Some older kids can, but usually it's caregivers. So as much as you can sort of protect this tubing thing from getting yanked on by the well-meaning caregivers, that will go a long way towards preventing accidental dislodgements. Now I'm going to show you how to change a tube, and this is exactly the way that parents do it in the clinic. We see them for their 2-week post-op, but then we have them return for their 3-month tube change. Inside the packet, there's a lube thing here that I'm going to open up. And here's my new tube. You don't have to memorize how much water goes in the balloon because it's written right on the balloon port in nice clear number, and this says 4 mLs. This happens to be a 14 French tube. AMTs have a variable balloon fill, so if you were familiar with Mickeys from the past, Mickeys, no matter what size Mickey, all got filled up with 5 mLs of water, but AMTs have a variable fill and it's printed on the balloon port. For example, all the 16s take 6 mLs, all the 14s take 4, all the 12s take 2.5. So you have to look and make sure you know what you're dealing with. And so I'm going to use 4 mLs in this one. I'll dip it in the lube packet here. Here's my 4 mLs of water ready to go. This is just clean tap water, drinking water, not sterile, nothing special. This is not a sterile procedure. This is just a clean procedure here. So I'm going to take an empty syringe in my dominant hand, and I'm going to grab onto the base of the tube with my supporting hand. Now, it doesn't matter how wiggly or uncooperative this kid is being. I can do this by myself, and I assure parents that they can too. There are some super wild kids, and sometimes you have to lay your body down over their legs so that they aren't kicking so much, but it really is usually possible to do this by yourself. Take your empty syringe and attach it to the balloon port. Pull out all the old water. You'll meet resistance when you have all your water out. That's how you know you're done. You don't have to take the syringe off. That's just an extra step for parents, and they're not so adept at these things as we are, so I don't like them doing any extra steps. Just lift the whole thing out. Comes out very easily, very easily. Now, if there's food in the tummy right now, it is going to start leaking out. That's okay. I usually have a towel or a washcloth here and cover over the hole. We reach over here to your new tube that's all pre-lubed. I hold it in my supportive hand, put my water syringe in the dominant, wiggle this right in, hook this up, blow up the new balloon. Done. Now you have to check placement. Take your syringe or your extension set, line up the black mark to the black mark, push, twist, two-hand technique. I'm going to close my main port here. I'm going to flush some water through here. Now it depends, like most kids, this is not pre-primed, and so this is about 2 or 3 mils of air here. If somebody's really sensitive to air, you'd probably want to pre-prime your tubing, but most of the time you can just flush it through with water and then aspirate, and you'll get gastric content in your tubing, just like you'd check with any other type of tube, and that's your position checking to make sure it's in the stomach. What if it wasn't in the stomach? What would it feel like if it wasn't in the stomach? Well, first of all, you wouldn't be able to get the water to easily go in here. It would be like doing an IM injection. You'd have to push it in under pressure, so that's not normal. And also, if you're pushing it under pressure and then you can't get any feeding back, then you'd be really worried, and you'd have to send this kid to fluoro for a G-tube study to see where this tube really is. But luckily, it's a very safe procedure to do in the home. We have a very, 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 very low rate of the tubes ever being displaced, and therefore it's super safe to teach parents how to do this at home, and they can feel very confident doing it. If you want to look at these things up close or try any of this yourselves afterwards, you can, and I have my little model here of the 3 different types. So feel free to take a look if there's anything else, and you can come up to me later if you have any questions. Thank you so much.